Yes, so his DLI was less than 1 in both his eyes. And that is how he was planned for a surgery under very guarded prognosis.
Okay. So I think you can share your screen and we can start. Huh?
Yes, sir.
We are joined by Dr. Anand Varthan. He's a guest today. And maybe Dr. Rohan will also be joining. Good evening, sir.
Evening. How are you?
All well, sir. बिल्कुल ठीक. आपके लिए आज हमने अच्छे केसेस 2-3 अच्छे केसेस रखे हुए वीडियो पे सर्जिकल, तो इंटरेस्टिंग केसेस है.
I hope my screen share is visible to everyone.
Yes, Amrita, please go ahead.
Yeah, so this is the first eye that we had planned for this patient. So
okay,
this,
I think we can give the background again. Like, how much was the refractive error of the patient? Approximately.
the
Was it
patient,
around -20 or something? I think.
Yes, sir. So the patient had an unaided vision of less than 1/60, and with the glasses, he was improving maximum to 6/36. And he had a refractive error of approximately 18 and 20 in both the eyes.
Okay. So we decided to do a cataract surgery for him because his on eye trace the DLI, the dysfunctional lens index was poor, right? Okay.
Yes, sir.
So please go ahead. What was the power of the lens which was planned, like for this patient approximately? Do you remember?
No, sir. I'm sorry.
I think it was -2, if I'm not wrong. It was a -2.
Yes, sir. It was -2 and -1 in other eye.
Okay. So first eye must have been -1. Second eye was apparently -2. So, yes, so let's go ahead.
So this is his first eye when we planned on doing the refractive lens exchange. So we started it as a routine case, and so the eye was very well dilated, and as a normal refractive lens exchange is planned, so we went ahead with it. We did a capsulorhexis marker and marked the capsulorhexis. We made 2 side ports in his right eye. Followed by phenocaine, and then to the main tunnel entry. Under the visco, the capsulorhexis was made. So the capsulorhexis was made in a circular and central way, and till now the surgery was quite uneventful. Hydro was done. And we did a lens matter aspiration for it. So during this time, we could actually sense some of the zonular laxity or the zonular weakness while making a capsulorhexis and also while doing the lens matter aspiration. Once the lens matter was aspirated, this is when we noted some folds, and also we noted the capsule was actually quite folded on the side, and thereby we formed the chamber with the viscoelastic, making sure that the the vitreous does not come into the anterior chamber, but still we could actually see the zonular laxity from one side and the capsule was folded. So we decided on going ahead with the capsular tension ring.
मम्मी कह रही है मेरा ड्राइवर चला जाएगा, क्या मैं यहाँ आ जाऊँ? अब यहाँ बुला लूंगी तो मम्मी मार डालेंगे.
The capsular tension ring was implanted quite uneventfully, and at the end we could.
Amrita, can you just hold it and pause it here? I
Yes,
think if you can just go back to that point where when we removed the phaco probe and suddenly the chamber shallowed, and
Yes, sir.
there was this vitreous which started peeking in through the capsular
Yes, sir.
from the side from one place. So can you take it there? So I basically, so just watch now. This, can you see on the left side what's happening? So what should we have done here at this point to prevent this? I think my voice is not audible, is it? I can't hear you guys. Maybe my network is poor, I think. Hello?
Yes, sir. You're audible, sir.
So, yes, okay. So maybe I missed you in between, but what could we have done at this stage so that this complication did not arise?
So probably once we considered that the capsular laxity or the zonules were a little on the weaker side because the patient being a high myop, so we could have implanted a CTR a step before this one maybe.
Yeah, but that would be in retrospect, because in retrospect it seems nice. At the time when we started the nucleus removal, we only felt that there was a little bit of laxity of zonules, and we had not anticipated that suddenly on this thing, as soon as the chamber was shallowed, that we'll notice this capsular sudden laxity from this nasal
so
from
probably
this side,
before
and then the
before
vitreous peeked out, and the vitreous has actually now come into the chamber.
Yes, sir. So before we remove the probe, we could have actually made sure that there wasn't a sudden fluctuation in the chamber, and we could have inserted the viscoelastic instead of doing it after removal of the probe. We could have done it simultaneously from the side port.
Absolutely. So basically, when you are faced with a situation where there is a potential zonular laxity, you can anticipate that because of the zonular laxity, there will be sudden significant shallowing of the chamber, which you want to avoid, because in that case sometimes you can have upthrust and you can have the vitreous peeking out from the side if there is zonular dehiscence on any of the sides, right? So
yes, sir.
So in this case we can actually I think put viscoelastic, as you said, to make sure that the chamber remains a little deep, and then only pull them. So essentially what you have to do is you have to keep the phaco probe inside, keep the infusion on, take viscoelastic from the side port, start injecting, and as you start injecting, then you can switch off the infusion so that there is no sudden shallowing of the chamber, and then fill the viscoelastic in the back, and then, then bring out the phaco probe at that point, right? Okay, yes. I think let's go ahead.
So after this, we did form the chamber with the viscoelastic and planned on putting a CTR.
We also inflated the bag.
Yes, sir.
So we also inflated the bag with viscoelastic, and we also did try to form the chamber. Again, here we used hydroxymethyl cellulose, thinking that that will be adequate here to take care of the situation. But again, I feel that in retrospect, if we had injected viscoat, viscoat retains much better. it would have pushed the vitreous back a little bit and not allowed more vitreous to come out. And it would have also, formed the chamber in a much better way than we could form with the hydroxymethyl cellulose. But immediately that was what was available. So we did not realize that and I had thought that, we can put in a CTR and that will take care of everything. So, okay. So you're putting in
Yes, so the CTR went inside the bag, and we could see that the capsule has been pushed way behind, and it seemed like a well-formed bag now for our implantation of the lens. So we went ahead with the cortex removal. So while we were going ahead with the cortex removal, we did note that the capsular zonules were actually a little lax from the other places also, but yet there was no folding of the bag. And I think halfway through it, we actually even realized that the pressure of the eye has suddenly risen like too much. So we had to come up with a next solution. So all we did was...
So I think, wait, let me just tell over here. Because, we lost the recording. You have to mention that we, inadvertently, the recording was lost at this point. And we noticed that there was vitreous because when we went in to do an irrigation aspiration of the cortex of the removal, for the cortex removal, we found that there was vitreous in the anterior chamber. So we went ahead and did a Tramslon assisted vitrectomy. And after we removed the vitreous, then we went back to try and remove the cortex. But each time that we did that, more vitreous would come from that area of zonular dehiscence. In spite of the CTR, it would keep coming into the anterior chamber. And we had to do Tramslon assisted vitrectomy almost 3-4 times. And with that, we were able to remove about half the cortex, which was visible at this point. Because every time we would start doing cortex removal, we would find some vitreous again in the chamber. And each time that we would remove it. So at one point, what happened is that we realized that now the vitreous bead is actually coming out from the side port. So I'm sorry that we don't have a video of that whole thing because somebody messed up in the OT to record it and could not record that last most critical aspect. So then we had suddenly we realized that there was vitreous peeking through the side port, and that's when I realized that maybe the IOP is high, because why should the vitreous be trying to kind of peep out from the side port even though we've done a vitrectomy and we have not filled viscoelastic into the chamber. So that point when I felt the eye with my finger, I felt that it was almost stony hard. And at this point, we also noticed that some of the iris started to kind of come out from there was an iris prolapse from the side port. And that's when we thought that there may be an expulsive hemorrhage which may be developing, and or a choroidal, suprachoroidal bleed, or maybe a choroidal detachment. So then we immediately sutured. So we sutured the side port first. And after that, we sutured the main port as well. And at this point, then we realized that things are getting better. And there was some iris which was also trying to come out of the main port. It was not out all the way, it was halfway out. It kind of, we put pilocarpine from the side port, and then the iris also kind of released from the main port where it was stuck. And after putting pilocarpine and making the pupil a little smaller, we had to abort the surgery with vitreous trying to peek out from both the ports, the side ports. And luckily the main port was spared because we did not manipulate it. So patient was given Dimox and everything, and the surgery was aborted, and both the main port and one of the side ports was sutured, and the surgery had to be cancelled. We did call the retina surgeon at that time, but there was little that we could do because without doing a B scan, it was not possible to proceed forward. So surgery was postponed at that point without putting an IOL, and with some of the cortex remaining in the back. So now maybe you can show us what happened after that.
Yes. So on a second sitting, then we the next day.
Can you show the pictures? Slit lamp photos.
So I think I'll just directly show the video because that also has the same thing. Just
okay. So what all treatment was the patient started on next morning?
So on that very day, the patient was also given on-table mannitol to make sure that the pressures come under control.
No. You have gone straight to the second surgery. I'm talking about second surgery was done after 3-4 days, right?
Yes, sir. So this is like I'm talking
on
about
post-op day 1.
Yeah. So on post-op day 1, when the patient presented to us, so the AC was formed. The vitreous, there was one strand on the same side port. So I think in this particular picture, everybody can appreciate there's a suture present on both the side ports that we've made. And because we were anticipating it to be a very high IOP, so we didn't even bury the suture knots. We left it as it is because we wanted to not have too much of fluctuation and manipulations into the AC. So this is when now the pupil looks very circular, but I think everybody can do appreciate a little bit of vitreous also in this particular side port. So that is when we thought about how to proceed with the surgery next, because obviously a young patient and we have to implant an IOL in this patient. So let's see how we can go about with it. So we thought we'll have a VR backup while we do the surgery. If in case the vitreous does not push back, then we can do a PPV and we can actually clear the vitreous from behind instead of doing more fluctuations in the anterior chamber. So
actually, let me just fill in this. The next day morning, we did a B scan and we confirmed that there was no, suprachoroidal bleed or any other anomaly in the posterior segment. And patient was started on.
ऐसा करियो बेटा, अपना फोन ऑन रखना.
Kamal, can you help us? So after that, a B scan was done and IOP was very high next day post-op. Even though the patient had been put on Diamox, it was still in the 30s or 40s, I think. And then patient was started on glaucoma medication, topical steroids, and good antibiotic cover to ensure quietened up. And after 3 days, patient was, on the third day, I think we had operated this patient on Tuesday. We went ahead with the, remaining part of the surgery on the Saturday. And that day, we obviously gave pre-medication with Diamox and mannitol. And also, we had VR backup so that in case we have a situation of that situation developing again, we can then tackle it intraoperatively. In fact, there was a thought that maybe we should go from the posterior segment and clear up, do a little bit of a vitrectomy first, and then go from the anterior route. But because in such high myopes, even vitrectomy is a risk, then risk of complications even from a pars plana vitrectomy. So we decided that we'll only do that if it becomes absolutely necessary. So now I think you can start showing what you're showing.
Yes.
It'll be good to have the slit lamp pictures of day 1 and day 2 post-op in between, because that will give a better idea of how the eye looked on first post-op day.
Yes.
Later on when you make this presentation again. Huh? Because this picture does not give a true picture of what we saw on the day of post-op day 1, right? Kamal, are you on the meeting?
So this is how when we went for the second intervention, this is how the eye of the patient looked like. So we had partially left in the cortex because of the area of the vitreous where it was trying to come out, and the rest of the cortex was cleared. So
आपके फोन से मैं आऊंगी तब डालेंगे.
डॉक्टर आनंद, आपका ना वो माइक ऑन है, उसको आप म्यूट कर लीजिए, वो ना आवाज बहुत आ रही है पीछे से.
So the first step is that we release the sutures on both the side ports. We can still see the vitreous strands in the anterior chamber. So we started the vitrectomy for the visible strand of the vitreous. But again, we realized that the vitreous, despite of the fact that we were doing a vitrectomy, but yet we could actually see a vitreous strand coming from the similar site where we had encountered the zonular dehiscence the previous time. So probably because it's a myopic eye with a very high myopia, the liquefaction of the vitreous does lead to recurrent prolapsing of the vitreous from the even a slightest zonular like dehiscence that we have in the periphery. So we went ahead and we did a triamcinolone staining for the vitreous. So this gives us a little better visibility of the vitreous strands.
So in fact, if you can notice here, in spite of all that we have done, the vitreous bead is coming out of the side port again. And this is exactly what was happening inside, in fact, during the surgery as well. And we had a very tough time because intraoperatively, the vitreous, more and more vitreous would keep coming out of the side port, which is, in fact, I had made a third port here because from this side port, a lot of vitreous was coming. So I didn't want to go in and out of this again and again because the dehiscence was in this area. So you can notice that I've made a third side port to avoid using that side port from where vitreous was continuously coming. And I wanted to go in from the other side port to kind of, remove this vitreous. So you can see what I'm doing here. I'm trying to go just above the bag. And okay, so here we are using the aspiration mode on the cutter. So no cut, only aspiration, and trying to do some aspiration with the vitrector itself. And this is a very useful mode, but I don't think it's available on our phaco machines. We were using the Constellation here, and we were able to aspirate with that because it had the mode. So, and now, basically trying to clear off. I think what was very useful here was to use the vitrector there for both the cortex aspiration, and whenever vitreous would present, we would be able to do a small vitrectomy. So I think going in with the cutter was actually very, very beneficial at that point because you could kind of switch between cut and IA and, and also just no cut and just aspiration. And that way we were able to kind of ensure that we could, you remove the vitreous as well as aspirate the cortex without using the cut mode. And it was a very dicey situation because again, patient was going into a similar situation where the vitreous was again peeking out of that side port constantly. But I wanted to be sure that we can remove the cortex. So we managed to somehow, and it was a very sticky cortex now, and that there was also obviously upthrust. So, and it was very important not to have a broken rhexis or a broken capsule as well, because and you can see that I'm having difficulty aspirating in that area because, it's like counterintuitive because the approach is not easy. Can you play it at a faster speed, Amrita?
Yes, sir.
If you can increase the speed to 2 times or 3 times, that will make it faster. So finally, we decided that, we will not remove some of that minimal remaining cortex. and we decided to implant the lens so that at least the lens will provide some tamponade to the vitreous as well. Enlarge the incision. We were going to use a 3-piece lens here, and that requires a slightly bigger incision. And luckily, I think with this, after we put pilocarpine, here I've put pilocarpine now. I'm trying to see if there is vitreous in that area. Can you take it forward a little bit? So now we put pilocarpine and hoping that the pupil will constrict. There was also a vitreous bead coming out of that third port. Somehow this patient had very, very fluid vitreous, and even now the eye was becoming a little hard. Maybe because the vitreous gets hydrated and then it starts coming out. Then we decided that we'll clean up if there's any more vitreous there and put in some more triamcinolone. And you can see that in spite of all our efforts, there is some vitreous still peeking out of that side port and causing a little bit of peaking of the pupil. Managed to get it out. So it's important to make sure that even now you can see a small strand going to that side port as well. And we obviously want to suture these ports because they're leaky. So can you take it forward now? So anyway, now you can take it to the end of this surgery, I think. So at the end, we checked for all the ports to see if they're leaky with triamcinolone, with the trypan blue, and made sure that all the wounds are secured. Didn't want to take any chance. And of course, intracameral moxifloxacin was given as well because there was a disruption at the posterior capsule. Not in the capsule, but at least there was a zonular dehiscence. So I think here we can then, our dilemma was this eye was done and patient eventually did well. We had to still do the second eye, which was still a -20. And now we were not sure how to proceed with the second eye. So we gave the patient a break of 2 weeks, called him back after 2 weeks, thinking that, we will be able to assess the second eye better and then operate upon it. So here I would seek suggestions from everyone that how should we plan the second eye differently from the first one so that we are not in the same situation. Especially from our retina colleagues, I would love to hear from them what we could do to prevent this kind of a situation and why in the first eye this situation happened in the first place. Like, we didn't anticipate any of these complications with the fluid vitreous, which would not stop coming, and maybe the reason that,
maybe that one reason was that the scleral rigidity in these very high myopes is very low, and the globe has a tendency to collapse and the vitreous is liquefied in a very high myope. So all those issues, I think, and once you start hydrating and if there's a zonular dehiscence and the vitreous is trying to come out from there, and you irrigate more fluid from the anterior segment only, so it goes and hydrates the vitreous at the back. And that is when it's a kind of a vicious cycle set in, and more and more vitreous keeps prolapsing. So I think that is what happened in your case, because it was not, I think, blocked. I think the first case was under topical, if I understand.
Yes, it was under topical, yes. So how should we have proceeded with the planning for the second eye? I mean, what should we have done differently for the second eye to prevent a situation like this?
So, I mean, I would say that maybe give a block, but block has its own issues because, it can increase the upthrust, but, at least the movements and the squeezing and all will not be there. And the other thing is that, I mean, I'm sure you looked preoperatively for any sign of zonular dehiscence in the other eye also. I had also seen this patient. pre-operatively. And major, I think you did a great job, and I think it was fortunate for the patient that I couldn't see any treatable lesions later also, or any RD developing, at least till now. But it was definitely a very tough case to manage. So I wouldn't really have. So my main concern is that when we had the VR backup, so the main thing is that yes, it is definitely more efficient to remove vitreous from the back, and it is commonly believed that if you cut the vitreous from the back, then less of it prolapses. But then going from the pars plana has its own issues, because you're entering through the vitreous base. So the chances of creating, and especially in a non-vitrectomized eye, when you have not done a complete vitrectomy and you are entering through the pars plana, the chances of break formation are very common. I mean, it's very high, even in such a high myope. And the other issue is that if we put a irrigation cannula into the vitreous cavity, again it causes hydration of the vitreous, and it can cause the vitreous to prolapse more. But till the time we haven't removed enough vitreous, done enough core vitrectomy, so I mean, there are issues. So it was not a very easy decision for me not to kind of intervene and keep seeing you struggle with that vitreous from the anterior segment, but because entering from the pars plana has its own issues.
Right. I agree. So I think all these issues were very difficult for us to deal with. And for the second eye, we made a plan that I didn't want to give blocks, because sometimes with blocks, with peribulbar blocks, the upthrust can be even more during surgery rather than under topical anesthesia. That's my understanding. But we did decide to give patient Dimox and mannitol prior to the surgery. And for the second eye, we decided that we will go for a more controlled surgery and minimize the time inside the eye. So we decided to go for a femto-assisted surgery, where we did a... Dr. Amrita, I hope you have the second video as well.
Yes, sir, I do.
So
I don't
let's
have the
see that.
femto part of it, but
You
I
don't
do
have to show the femto. Yeah, you can just show us the... we decided to also increase the size of the rexes from 5 mm to just 5.25 mm on the femto. And that was so that we have better access to the cortex in the periphery, and also because we were planning to put in a CTR and everything. So here the different thing was that we did a femto assisted cortex, the cleavage of the nucleus, and we made a rexis. So this way at least we were confident that there will be shorter time spent inside the eye, rather than because even doing the rexis, sometimes you can start having upthrust, you can have a rexis complication, and we definitely did not want a broken rexis in the second eye as well. So we decided that at least our rexis will be secure, and also the nucleus will be cleaved. So can you play it? Yeah.
Yes, sir.
Is there a fast forward mode on your
Yes, sir.
No, can you increase the speed of this playback by twice or thrice?
Yes, sir, I have increased it. I think it will
Okay,
be
great, perfect. So in this eye also the lens power was -2. And the other critical thing we did differently was that at no point did we allow the chamber to collapse. So we were ensuring that, as Dr. Amrita said, that we keep the visco filled inside the end. We were using viscoat this time, which retains much better than hydroxymethyl cellulose. And okay, so the other new thing that we did was that right at this point itself, anticipating that once the nucleus and the cortex is debulked, the capsular bag can start collapsing as it did in the first case. We introduced a CTR right at this point before starting the nucleus removal at all. So this way, we try to ensure that when the capsular bag becomes debulked, we should not have a capsular bag collapse as we had before, and then vitreous may start coming in from the side. So we were securing the zonules. And then we went in with this cortex. Now, in retrospect, I feel that, using this bimanual to remove all this cortex, although the patient was just about 25 years old, prolonged the surgery for us. I would have rather gone in with a phaco probe and done a phaco aspiration of this, The reason I did not do the phaco probe was because then you're going through the main port. So the fluidics are much stronger and the chance of chamber collapse is much more. So I wanted to avoid using the main port for, phaco aspiration. And I thought this may be more controlled. And it was more controlled for sure, but it did also prolong the surgery. So I think it was a catch-22 situation. If we use the main port with the phaco probe, we could have done this much faster, but then also exposed ourselves to the risk of hydrating the vitreous more if some fluid was going behind, because the fluidics would be much stronger there. And here you can see that now I'm again putting viscoelastic and then bringing out my infusion and then switching my hands and going and finishing off the cortex on the other side. And so you can imagine that while this is on fast forward, and my speed would have been actually half or 1/3 of what we are showing here, because I had to be very cautious that we don't have a complication of a capsular break or something. Now we are again, you can see I'm putting viscoelastic before withdrawing my infusion, and again filling viscoelastic so that we don't at any point allow the chamber to collapse. And then here we could put in the lens as before. You have to enlarge the incision a little bit to about 3 millimeters. And even in this eye, it felt very, very challenging because the capsular bag was very peculiar and it was tough. So here we were able to implant the lens and close up. So I don't remember whether we sutured it or not. I don't think we sutured it though. So I think this was the end of surgery. In this eye, patient did fairly well as well. And we were able to save the situation in the second eye. So I think you can stop sharing, Dr. Amrita.
Yes, sir.
We can have a small discussion if anybody would like to give any comments or suggestions. Any of Dr. Avijat, Dr. Vaibhav, do you have any thoughts?
So I just had a question. Was like marfanoid, habitus ruled out in this patient, or like did we look into that whether the patient had, because he was a little not sure whether
No, he did not really have any marfanoid habitus at all. In fact, I did look at that aspect as well next day, because initially we had not noted anything, but then post-op in retrospect, when we looked at this patient, it was there was no such risk factor at all, and there was no way for us to anticipate. That was the craziest thing. I've been operating for so many years and so many high myopes, but I've never felt got into a situation like this where spontaneously the vitreous would just keep coming, and whatever you might do, it would not stop. And most often, when we kind of do a limited vitrectomy and put in a CTR, the vitreous stops coming. But here, and there was no scleral collapse as such. In fact, it just became a hard eye. In fact, frankly, there was no scleral collapse at all. And it just became a stony hard eye, halfway through the surgery. And that's why the vitreous just kept coming. And I was really concerned that we are going to eventually have a, kind of an expulsive kind of a situation. So I think we can have one presentation by Dr. Amrut, by Dr. Tulsi, if there are no thoughts on this.
Yes, sir. So before that, can we, like, when we come across such a high myopic patients, can we do a scan sitting and supine position to assess for the zonular integrity?
Absolutely. I think that would be invaluable, because we typically do a lens star, but we can, in addition, do a supine A scan and see if there is a difference in the AC depth which is picked up. In fact, preferably we would actually do it with the A scan itself in the sitting and the lying down position, rather than go with the lens star, because they tend to show a little difference in any case, right? That's
Yes.
a very good suggestion.
Sir, I have one question.
Yes, Dr. Esther.
Thank you for sharing this very complicated case in the first place. So, I mean, it's one of the rare complications that we can see. I just have one doubt, sir. Both the cases you had done cortex aspiration after the CTR ring has been placed. So, I just wanted to know how different was it? How
So, you're absolutely right. In fact, we tried to arrange a Henderson's ring for the second eye. The Henderson's ring is little different from the capsular tension ring because, it is kind of like twisty, so it has areas where it will not be in contact with the bag in the equator. So it will, have a, it will be much easier to kind of get the cortex out. So, however, we could not arrange it because none of the Indian manufacturers is making Henderson's ring. And but in future, we hope to keep in stock one Henderson's ring, although it's very, very expensive. But yes, so when you remove the cortex in the first eye, because the cortex was only minimal when I put in the CTR, I did not face a huge challenge. But I mean, so it was not really trapped behind the CTR as much as it sometimes is. So it was not bad. In the second eye, I did something to prevent that. So what I did in the second eye was that I did a small fluid wave hydrodissection, and then I ensured that when I put in the CTR, I go just under the capsule. So I was kind of tenting up the capsule and reached the equator, and then I started pushing in the CTR. So I made sure that in the second eye, I was not trapping any of the cortex. Had I done an hydro delineation and put in the CTR, it would have, trapped much more of the cortex. So I was very particular in the second eye that I got a good fluid wave and a cortical cleaving hydrodissection. And I introduced the CTR in the cleavage space place between the capsule and the cortex so that there was no risk of, having. So there was almost no cortex trapped under the CTR in the second eye.
okay, sir. Thank you, sir.
Thank you, welcome. Thanks for bringing out this point. I think that was something which we also did. So I think let's go on to the second interesting case.
Yes, sir. Are my slides visible?
Yes, Dr. Tulsi.
Hello, everyone. We'll be talking about CXL enhancements now based on this case discussion. So, 18-year-old gentleman who presented to us with complaint of blurring of vision and itchy eyes, and he gave a history of rubbing his eyes, and he had uncorrected visual acuity of 612 in the right eye with correction of -4 spherical, -3 cylindrical at axis 60 degrees with improvement to 6.6 partial. In the left eye, he had 618 with -3 spherical, 2.25 cylindrical at 170, improving till 6.9. And his cornea on slit lamp examination, the positive findings we found were in the cornea, paracentral corneal thinning was found, especially in the inferior cornea, and other signs which are classical to the keratoconus like Vogt striae, Fleischer's ring, and prominent corneal nerves were noticed. And in the retinoscopy, we also observed that there is scissoring reflex. And so we ordered for Pentacam, and Pentacam revealed in both eyes keratoconus, which is very evident, and which is mild in left eye and moderate in the right eye. So before going into the details of this case discussion, I would like to give a brief overview of keratoconus and how do we identify it in corneal topography for the sake of posterior segment fellows. So keratoconus is classified into clinical, subclinical, and keratoconus suspect. In clinical keratoconus, we find slit lamp signs and also scissoring reflex in retinoscopy, and a few signs which I'll be mentioning in subsequent slides in the corneal topography, characteristic signs. And in earlier subclinical keratoconus, we do see topography changes in Pentacam and scissoring reflex, but we don't find any clinical evidence of or signs under slit lamp. In keratoconus suspect, we don't see any signs, and also we don't see any retinoscopic scissoring reflex, but we do see some characteristic signs in topographic pattern when we see Pentacam maps. So this is a sample of a pentacam map with the showing sagittal curvature here and corneal thickness. Sorry for the poor clarity. This is sagittal curvature, and this is corneal thickness, and this is anterior elevation map, and this is posterior elevation map. So when we see a case of keratoconus in the anterior curvature map, one of the characteristic finding is inferior steepening, as we can see here. So here the colors, all the warm colors here, they indicate steepening, that is above the normal level, and cold colors indicate below the norm, that is depression or flattening. So in the anterior curvature, as I said, we see inferior steepening, which is characteristic of keratoconus when there is an inferior cone. And in the anterior elevation map, we see an island of elevated points. And similarly, in the posterior elevation map also, we see a island of elevation points, and which will be mostly corresponding to the where the steepening happened. And also similarly in the thickness map, we do see a corresponding decrease in the corneal thickness, which corresponds to the point where the steepening happened. So all the values which are related to these maps will be displayed on the left side of the topography. And as I mentioned, these are the topographic patterns. Along with the inferior steepening, we can find a superior steepening also, asymmetric bow tie pattern, and central steepening with asymmetric bow tie pattern combination will also be present. And if there is a symmetric bow tie, if there is which is coexistent with a skewed radial axis, we can consider that as a keratoconus. So this is one of the classification which is divided into stages, which is not used much now in the clinical practice. So now coming back to the case, this is a case, right eye showing moderate keratoconus, and left eye showing mild keratoconus. As we can see here in the classification, stage 1 less than 48. Stage 1 is mild keratoconus, stage 2 is moderate, and more than 53 is advanced keratoconus, stage 3 and 4. So here, as it is less than more than 47, it comes under moderate, and this is less than 48, it comes under mild. Sorry, more than 47 comes under moderate. And so because of the presence of evident keratoconus in both eyes, we went ahead and decided to do CXL to stop progression of the keratoconus. We chose a epi of CXL procedure in both the eyes. So which was done in the right eye first in July, followed by left eye 1 month later. So I would like to mention about the criteria parameters which indicates that the keratoconus is progressing when we see the patient in the subsequent visits. Among them, 4 important in this table there are many parameters which indicates about the progression of the keratoconus, and few indices are also indicated here. But most important ones and easy to appreciate are Kmax, pachymetry. Kmax is which is seen in the sagittal curvature. Pachymetry is the corneal thickness, can be seen in corneal thickness map, and about the refraction. So when the Kmax is more than 1 diopter, and pachymetry, if there is more than 2% decrease in the central corneal thickness, and if there is a change in cylindrical power of more than 1 diopter in 12 months, or if there is change in spherical equivalent of more than 0.5 diopters in between 3 months duration, 3 months interval, then it is considered that the keratoconus is progressing. So this is one of the famous analysis map, which is incorporated in the pentacam, so called as ABCD classification or ABCD progression display map. This map actually it differs from There is another map incorporated in Pentacam called as BAD map, or Bellin-Ambroisio ectasia display map. That map actually designed to differentiate a normal case and the keratoconus case, whereas this map is exclusively for to know about the progression, in which we already would have diagnosed the keratoconus, and then we wanted to know if the keratoconus is progressing or not. Then we use Bellin ABCD progression display map. It is yeah, this is the ABCD progression map I was talking about, and this shows bar diagrams. The colors indicate that the green color, thick green colors here indicate that the patient is having values of a normal population, and red values, orange or brown values, light brown and brown values indicate that the patient is having values which falls under having keratoconus. So in this progression map, the bars, generally we see the change in the length of the bars from one visit to other visit to know if there is any progression. So this first column indicates about the anterior sagittal curvature, and the second column indicates about the posterior corneal curvature, and third column about the thickness or pachymetry, and fourth about the visual acuity. So now coming back to the case, after 2011, when a patient did not
Dr. Tulsi, can you go back to that slide, please?
Yes.
Dr. Tulsi, can you go back? Okay. So, I'm not sure whether these colors have that implication as you suggested, that, the warm colors and the, the red color and the green color means that the green is getting better and the red is getting worse, or the brown. It basically, if you look on the right side, these colors signify the visit. Okay. So if you look at the top of these columns on the right side, the first column is orange, and that shows that 2011 visit. And then there is, we can zoom in if we want. Each of us can pinch in and out if we want. The second visit, which is dark green, shows the visit from 2015. And then the brown one shows the visit from 2020. And then the last column is the lighter green, which is from 2021. So if we look at the 4 bar maps on the left side, the first one is for the anterior curvature. The second group of 4 is for the posterior elevation. The third one is for pachymetry. And the fourth one is for best corrected visual acuity. So essentially what this is showing is, and if you see these horizontal lines on the ABCD display, these are showing the normal, where, it would be significant or insignificant, whether, these bars are crossing them or not. So these are the lines which we typically use for a normative, like a database kind of a thing. So if you notice, this patient started with the anterior maps with the orange, where he was diagnosed with keratoconus. Now, patient was probably lost to follow-up and was seen 4 years later in 2015 and had progressed still marginally, but not significantly on the anterior curvature maps. So he was relatively stable. And if you look at the second group of the 4 displays, then on the posterior curvature maps on the second visit, the dark green is much lower than the first orange. So that shows that the posterior curvature has actually stabilized and it has improved at this point. And if you also look at the third group of maps, which is the corneal thickness, you'll notice that again patient is doing well, because considering that he was initially on that orange, in the third group of the pachymetry maps, his patient has stabilized, and so that's why that bar is much lower. But if you notice that after that, when the patient comes back to us in 2020, again he was lost to follow up, he again shows a progression. So the dark brown in the first group is showing a substantial increase, which means he has steepening of the cornea in the anterior curvature maps. And that is when we decide that also, if you look at the posterior curvature, that again has shot up, that brown column in the second bar graph, So in the second group, again, that thing has shot up like crazy. And if you look at the pachymetry maps also, they have also showing that the corneal thickness has decreased. That is why the third bar has also gone up. So essentially, this is the progression of keratoconus, which is typically seen after 7 to 8 years of cross-linking in some patients, because the collagen has got recycled. So that is why now new fresh collagen has been laid down, and the compacted collagen, which was strengthened or cross-linked, has been probably reabsorbed. So that is why some patients will start showing a progression, and it's critical to start watching patients in the 6th or 7th year annually. You can't let them go away, and that is why here is the situation where we decided to retreat. The Excel was done again. So now maybe Dr. Tulsi, you can go ahead, and this
Yes.
makes it easier to understand these graphs.
The green line and the red line I was mentioning about, or these lines, which indicates that the
You can go to the
values
next
are
slide,
falling
Dr.
under
Tulsi.
the normal or keratoconus population. So in the next visit, when we looked upon AR values of the visual acuity, we found that there is slight flattening in the left eye. So we didn't decide to again cross-link the patient, and we wanted to see in the next follow-ups and call the patient after 6 months. But again, the patient didn't turn up, and straight away he came to us in 2020. So these are the compare maps between 2011, 15, and 20 and 21, which anterior sagittal, which shows comparison between the anterior sagittal curvature maps. And as you see here, there is an option to select between and compare between the two values between A to B and B to C and C to D. So when we see a comparison between C to D, that is our first visit and second visit. After in the first visit, we went ahead and did CXL. So when we saw the patient in the second visit, there was no much progression in the visual acuities or the anterior sagittal curvature, and also thickness was also almost the same in the right eye. And in the left eye also, anterior sagittal curvature and thickness were maintained between first visit and second visit, where the CXL was done. And in 2020, this is our third visit. We saw that in the left eye, there was some change in the visual acuity and deterioration in uncorrected visual acuity. And when we see the compare maps between 2015 and 2020 anterior sagittal curvature, there is no much change in the right eye. And also thickness is also not much changed. But in view of, I'm not, sir, I wanted to ask you about this visit, because in the anterior sagittal curvature and pachymetry, there was no much change actually observed, but there was a change in visual acuity. And we actually didn't do it for the left eye and right eye, and we did a CXL enhancement in the left eye. So I'll show you this anterior sagittal curvature and thickness maps, if you can discuss on this.
Left eye.
Hello.
So I apologize. My network is very poor, so I can't hear in between, and the voice is dropping. So, are you able to hear me? I'm not
Yeah,
sure.
actually, Dr. Tulsi had a question for you. I think maybe Dr. Tulsi, you can repeat the question.
Sir, so in the visits, when I saw the sagittal curvature and pachymetry maps, I couldn't find any gross change in the sagittal curvature values or pachymetry values. I found that the cross-linking was done only in the left eye in 2021. So I wasn't sure about on what basis the cross-linking was done. So I was not sure about it. So I wanted to ask you if you can see the maps and.
So, Dr. Tulsi, was there a fall in vision for this patient between when he presented to us in 2020?
So this is the AR changes, sir, what they have recorded in. MR.
Hello?
Yes, sir. Can you hear me, sir?
I think my network is poor, so I can't hear much of what's.
So this is a a serial follow up for this patient showing the
sorry, I
AR
can't
changes and the
hear you.
vision.
Please carry on.
So generally, when progression of more than one diopter or a change in the thickness of 20 microns, or there is a change, fall in the thickness of 2% when it is observed in sagittal curvature and thickness maps, generally CXL is repeated or the primary CXL is done. This is a criteria for deciding upon doing CXL. So in this patient,
Can you show us the pachymetry map for the 4 compare maps for the left eye?
Is there a signal loss? I can't hear much.
Even I'm not able to hear anything right now, so I'm wondering that whether it's my like poor network for me only, or okay.
I don't know.
So let's just
Somehow
stop
we're
on
not
this
able to
screen,
listen
please.
anybody. I don't think
And if
anybody.
we notice here, there is. Can you go back to the pachymetry maps? No, you were showing the left eye 4 maps for pachymetry. Yes. So if we notice here that the patient started off, the pachymetry was 450 in 2011 at the thinnest point. Please stay at that map. Yes. Is it the left eye? I want to see the left eye pachymetry maps. Can you take us to the left eye pachymetry maps?
I
So
think these are the left eye because
Yes, just stay here on this slide. Huh? So if we notice that when we started off, the pachymetry was about 450, and post CXL, there will always be some compaction. So the pachymetry has gone down, and this can also happen with progression, but it can happen with compaction. The pachymetry has gone down to about 420, and that was in 2015. And then when the patient presented to us in 2020, we noticed a further fall in pachymetry to just about 412 there, I think. Now, this was one of the warning signs that there was progression of the keratoconus, the parameters that may have changed. And that is the time when the patient was probably, also had a fall in vision by 1 line or something. So that is why patient was, offered to get us a repeat CXL in the left eye. And that is how I think we were able to, arrest the progression in the left eye. And the right eye was kept on monitoring because that was the better eye, I think. So I think I think we can kind of summarize, Dr. Tulsi.
yes, sir.
What's the take-home message? How frequently should we monitor keratoconus patients who have been cross-linked or who have not been cross-linked? And is there an age criteria when monitoring should be more important and other stuff?
Yes. In generally pediatric CX,
Am I audible?
pediatric patient, your voice is not very clear, sir, but can understand what you're saying.
So I think I am having poor network, so I can't hear anything from anyone.
You are audible, but you were like breaking up in between. But I think Dr. Tulsi got it. She's going to conclude. Yeah.
I'm
yeah.
sorry, I can't, kind of hear anything. So maybe my network is poor at this time.
Dr.
I
Tulsi,
don't
I
know
think
if
you can
anybody
summarize.
else is
Yes, sir. Yes.
having this
So
issue.
So
Go ahead.
initially, when you see a patient who is very young, around 15 to 20 years, so if it's mild keratoconus, do not wait for and see for progression. Then, because the chances of progression in young patients and adolescent group is very high, so we straight away go ahead and cross-link the patient, and then we'll monitor them every 6 months to 1 year, and treat if there are any risk factors like allergy, and place them on topical steroids and follow them up. And if you see in subsequent visits, if you see that generally after CXL, after primary treatment of CXL, it generally lasts for around 5 to 10 years. So in very few cases, if the patient has any predisposing factors which is uncontrolled, like for example allergy, so which is uncontrolled, and the patient keeps on rubbing his or her eyes, then the progression is bound to happen even after CXL. So in such patients, we do monitor and see if there is any gross change in the keratometry values or decrease in the pachymetry in the subsequent visits. Then we prefer to do a repeat CXL or CXL enhancement depending upon corneal thickness, K values, and visual acuity as per the Bellin ABCD progression display map following that.
Okay, thank you, Dr. Tulsi. I think I'm not sure, but I think Dr. Gaurav's connection is unstable. And so if there are any other questions,
So I think I was able to hear the last bit, and the message is clear that keratoconus patients can progress even beyond the age of 25 to 30 years. They need to follow up, and especially on the 7th or 8th year after their cross-link, we have to become even more careful. I'm really sorry. My network is really poor today. So, Dr. Saurabh, can you close the meeting and plan for?
Yes. So thank you so much, everyone, for joining. And so the coming Tuesday, we will have a
so
presentation.
that everybody is
Yeah.
able to know what we're doing in the next meeting.
Right. So thanks, everyone. And in the coming Tuesday, we will have a presentation by Dr. Abhijat on brolucizumab, for AMD. And he will also be showing some cases, some patients in which we have used brolucizumab for refractory AMD. So looking forward to having the class on Tuesday. Thank you so much, and I think we'll call it a day now because it's already 8:45. Thank you.
Thank you, sir. Thank you.